we now go to an excellent concept medical session, which is on overcoming the limitations of Paclitaxel, a new Sirolimus Coated Balloon for the treatment of peripheral arterial disease, to be chaired by Francesco Liistro. Francesco.
So, thank you, Roger. And will be an interesting session. We immediately go to the first presentation, which is the prospect and appraisal of a new Sirolimus Coated Balloon over Paclitaxel for the treatment of peripheral arterial disease by Dr. Finn from the United States.
Good afternoon. Thanks to Concept Medical for inviting me to give this talk. Today I'll talk about the prospect and appraisal of Magic Touch Sirolimus Coated Balloons over Paclitaxel for the treatment of PAD and AVF. Here are my disclosures. But we have two agents known to inhibit restenosis when delivered from stents or balloons, sirolimus and paclitaxel. Sirolimus is a cytostatic drug which inhibits intimal hyperplasia by preventing smooth muscle cell proliferation. Paclitaxel is a cytotoxic drug which inhibits neonatal growth by causing toxicity to cells and essentially killing them. Well, what is the problem with paclitaxel? You can see here in this nice study in which paclitaxel was delivered from stents at differing doses in the porcine coronary artery model, that as the dose of paclitaxel is increased on the stent, neonatal area is decreased with higher doses. But the problem is that we also get increased toxicity with higher doses. Neonatal fibrin goes up as the paclitaxel dose is increased, which is a marker of delayed healing, and medial wall cell necrosis increases as well as the paclitaxel dose is increased. And you can see here that on the slides, as you increase the dose of paclitaxel to 187 micrograms per stent, you get lots of malapposition and fibrin deposition, both of unwanted. Well, what is the advantage of sirolimus over paclitaxel? Well, sirolimus is equally effective, if not more effective, at inhibiting smooth muscle cell proliferation and migration, but it has a much wider safety margin. If you increase its dose, it's not likely to cause toxicity, whereas paclitaxel must be tightly controlled in order to avoid the kind of toxicities I showed you earlier. We also know from the Katsanos meta-analysis that the risk of death following the application of paclitaxel-eluting stents or balloons for above-the-knee peripheral artery disease increases risk of death in patients being treated for peripheral arterial disease with paclitaxel products. This was quite a worrisome meta-analysis and has, I think, influenced the field quite a lot. What about Sirolimus Coated Balloons? What are the technical challenges? Why haven't they been created as yet? Well, we certainly know sirolimus, we need to enhance tissue absorption. It's difficult to get sirolimus to enter the arterial tissue within the time of balloon inflation and stay there. We have to extend its tissue retention. It has to have some sort of carrier to increase its permanence over time to maintain therapeutic levels to inhibit intimal formation. Well, how does the Magic Touch Sirolimus Coated Balloon overcome these limitations? It uses submicron particles of sirolimus surrounded by a phospholipid carrier and transfers these particles to the arterial wall, where it allows for sustained release of sirolimus over time. It addresses many of the limitations of paclitaxel. In a preclinical study we implanted porcine femoral arteries with a drug-coated balloon, the Magic Touch, at 3x dose or a control balloon, and we followed these animals for 28 days, at which time they were sacrificed. And you can see when you think about drug effect in terms of histologic parameters, we don't usually look at restenosis in this model because it's low injury. You can see that those markers of drug effect, including medial periglycan collagen score, as muscle cell loss, depth, and circumference, were both increased significantly with the Magic Touch 3x dose, showing you efficacy of the product. What about pharmacokinetic data? We certainly want to know that sirolimus is there in wanted places where it's delivered, but not in unwanted places. You can see blood concentrations of animals treated with this Magic Touch Sirolimus Coated Balloon in the coronary artery. Drug levels in blood went down to undetectable by 33 days. You can see that the DCB treated sections of our arterial wall had detectable drug levels at therapeutic ranges, but areas proximal and distal to that did not have any evidence of drug levels. What about the downstream territories of the heart, downstream of the treatment? You can see that areas that were treated with the Sirolimus Coated Balloon, the downstream myocardium had undetectable levels of sirolimus, which is a good thing. We want the sirolimus to go where we want it, but not go to non-target tissues. And in terms of organs, there was very little sirolimus found in almost all the organs of the animals. So in summary, I think I've shown you needle hyperplasia is a major cause of restenosis. Pharmacologic agents used in DS and DC mainly inhibits muscle cell proliferation. The most commonly used antiproliferative agent is Paclitaxel. However, it's certainly limited by its narrow therapeutic index and worrisome clinical data in terms of mortality. The Magic Touch Sirolimus DCB has a novel coating technology allowing for better tissue retention of sirolimus, and our preclinical studies support the efficacy and safety of the Magic Touch Sirolimus Coated Balloon, which should be a valuable option for the treatment of peripheral arterial disease. Thank you for your attention.
So thank you, Dr. Finn, for this drug elution review. And now we're gonna move to the real data, the 6 months Ecstasy result and the rationale for randomized trial of Sirolimus Coated Balloon versus POBA by Dr. Chok from Singapore.
Thank you for the opportunity to present at Charing Cross 2020 XTOSI's 6 months result of Magic Touch Sirolimus Coated Balloon for SFA and BTK disease. These are my disclosures. XTOSI is a prospective, non-randomized, all-comers single-arm trial investigating the efficacy and safety of Magic Touch Sirolimus Coated Balloon for peripheral arterial disease. 50 patients were recruited. Efficacy endpoint was primary patency at 6 months, defined by duplex peak systolic velocity ratio of 2.4 or less. Safety endpoint was defined as a composite of freedom from 30-day mortality and amputation and 6 months target lesion revascularization. Of the 50 patients enrolled, 20 target lesions were femoral popliteal and 30 were below the knee. 40 patients reached the 6 months primary patency endpoint. 6 had died, 1 underwent amputation, 1 withdrew, and 2 did not attend their scheduled 6 months duplex. Many patients were high risk with critical limb ischemia. Majority had diabetes, a significant were dialysis dependent, and a third had coronary artery disease. 80% of patients had ASA scores of 3 or more. 94% of patients had wounds with Rutherford scores of 5 or 6, and more than half of these patients with wounds had Wi-Fi scores of 4 or more. Lesions were long, and a third had chronic total occlusions. A quarter of patients required retrograde access to cross the target lesion. This is the key result slide summarizing 6 months primary patency. When considering the entire cohort, 6 months primary patency was 80%. For femoral popliteal lesions, 6 months primary patency was 88%, which was comparable to results of Paclitaxel coated balloon from the Ranger SFA and Levant Lutonix RCTs. However, in these trials, these were mostly on claudicants rather than critical limb ischemia patients. For below-the-knee lesions, 6 months primary patency was 74% compared to the 42% 6 months primary patency of Paclitaxel balloons in the Singapore single-Pacli RCT. 6 months freedom from major adverse event was 86% for the whole group, 89% for femoral popliteal, and 84% for below the knee. 6 months freedom from target lesion revascularization was 90% for the whole group, 94% for femoral popliteal, and 87% for below the knee. 6 months amputation-free survival was 85% for the whole group, 90% for femoral popliteal, and 82% for below the knee. There was a sustained improvement in toe pressures at 6 months for both femoral popliteal and below the knee lesions. To summarize the XTOSI trial, Magic Touch Sirolimus Coated Balloon showed promising 6 months primary patency in a cohort of critical limb ischemia patients with long lesions. Of note is the below the knee 74% primary patency, which would seem better than paclitaxel using historical literature for comparison. It also showed a good safety profile. There was no flaking or distal embolization, making it ideal for small BTK arteries, raising the question of how low can you safely go? What about below the ankle indications? I will show a case study of application of Sirolimus Coated Balloon to the plantar arch. This 76-year-old gentleman had a non-healing shin ulcer for 1 month, and here you can see he has a single runoff via the peroneal and collaterals into distal PTA with very little flow into ATA and dorsalis pedis arteries. Wire crossing into ATA was complex, requiring a two-stage approach, first stage being retrograde puncture of PTA, followed by pedal plantar loop approach into ATA, after conventional balloon angioplasty, 2.5 mm magic touch sirolimus was applied to plantar arch, followed by another 2.5 mm magic touch sirolimus coated balloon for distal ATA, and finally 3 mm magic touch sirolimus coated balloon for proximal ATA. Final angiogram run showed good flow into ATA, dorsalis pedis, and round the plantar arch into the lateral plantar artery with no evidence of distal embolization or slow flow phenomenon. I will finish this presentation with a brief description of plans for 2 randomized controlled trials of Magic Touch PTA versus conventional balloon angioplasty. These trials are named the Future SFA and Future BTK trials. We hope to recruit in Q3 2020. This will be double-blind, 2-to-1 enrollment across 12 sites in 3 countries, and we look forward to the results in 3 years' time. Thank you.
Thank you, Dr. Chieh, for this beautiful presentation and this interesting data. Now we move to a more complex scenario, the AV fistula, with Dr. Suai and outcomes of Sirolimus Coated Balloon in the treatment of dysfunctional AV fistula and AV graft. Please.
Thank you for the chance to share on the use of Sirolimus Coated Balloon in the management of dysfunctional AVF and AVG. A functioning access is critical to the delivery of life-saving hemodialysis therapy in patients with end-stage renal disease. However, new intimal hyperplasia often occur within the dialysis circuit, resulting in stenosis, poor flow, and ultimately thrombosis of the circuit. The situation is worse in patients who have poor veins and require AVG creation. No intimal hyperplasia often occur at the gravity junction, which can lead to thrombosis of the access. Although we are able to successfully salvage thrombosed AVG, the patency rate after successful salvage remains poor. Sirolimus Coated Balloon has been successfully used in coronary artery intervention by preventing new intimal hyperplasia in the arterial system. We therefore postulate that the application of Sirolimus Coated Balloon in the dialysis circuit will be effective in inhibiting new intimal hyperplasia and therefore prolong the durability of intervention. Hence, we carried out a single-center prospective study of 20 patients who presented with thrombosed AVG. Sirolimus Coated Balloon is applied at the gravity junction after successful endovascular salvage, and the patients were followed up at 3 and 6 months of duplex ultrasonography. The primary endpoint was set as the primary patency rate of the AVG at 3 months, and the secondary endpoint was the patency rate at 6 months. These are the baseline demographic data of the 20 patients that were recruited. The median age was 68 with a predominant female population. The etiology of ESRD was diabetes mellitus and hypertension in majority of the patients. The median vintage of the AVG was 14.5 months and were predominantly in the brachial axillary or brachial bacillic configuration. TPA was the thrombolytic used in 2/3 of the cases. 7 mm high pressure balloon was the predominant balloon used to treat the culprit lesion, and cutting balloon had to be used in 20% of the patient. The size of the sirolimus balloon used ranged from 7 to 8 mm. Most significantly, none of the patients had any significant residual stenosis or thrombus after the procedure. This is the result of our study. The primary patency rate at 3 months was 76.4%, with 3 patients experiencing rethrombosis within 90 days and 1 had repeated angioplasty performed for low flow. Therefore, the primary assisted patency at 3 months was 82.4%. 3 patients exited the study due to complications before the 3 months endpoint. The complications were unrelated to the use of Sirolimus Coated Balloon. 1 had surgical revision, 1 passed away from intracranial hemorrhage, and 1 had explant of the AVG due to infection. Significantly, this AVG were patent at the time of event. The primary patency at 6 months was 64.7% as 2 patients had rethrombosis of the excess at 134 and 157 days post-intervention respectively. If we compare the data with what is in the literature with regards to the patency of AVG after successful salvage, we can see that the rates using Sirolimus Coated Balloon was significantly better than what is reported using plain balloon or Paclitaxel coated balloon in our center. Even if we account for all the 20 patients that were recruited in the study, the rates were still significantly better. This is how the Kaplan-Meier curve looks like. The projected median primary patency can be up to 381 days. This is one of our first patients who was recruited in the study in 2018. Post thrombolysis, the graft vein junction was treated with Sirolimus Coated Balloon, and this is the appearance on DSA. The graft remained patent for more than 1 year before the patient was referred back to us. This is how the graft vein junction looks like 13 months after treatment with Sirolimus. Significantly, the patient did not require any intervention in the 13 months interval. Encouraged by the results of our pilot study, we went on to perform a single-arm pilot study to examine its effect in AVF. This was led by Dr. Tang Chunit from our vascular department, where a total of 25 patients were recruited, and these were the reasons for intervention. Impressively, the 3 and 6 month circuit patency were 93.9% and 68% respectively. These appear to be most effective with stenosis which were recurrent in nature. If we compare the patency rate of Sirolimus Coated Balloon with what is published in the literature for AVF intervention, we can see that the Sirolimus Coated Balloon angioplasty was as effective as Paclitaxel Coated Balloon. In conclusion, from our 2 pilot studies, we demonstrated the safety and effectiveness of using Sirolimus in treating dialysis access dysfunction. Larger randomized studies are required to confirm our findings. Thank you.
So thank you, Dr. Shok. Now, I will explain in 1 minute our next study comparing Paclitaxel and Sirolimus in BTK, please. The debate BTK DueIL, it's a randomized multi-center trial that will compare 2 different drug elution technologies, the drug-eluting balloon, the Paclitaxel eluting balloon from Acotec Scientific, the Liistro, and the Sirolimus eluting balloon Magic Touch from Concept Medical. The study will include patients with critical limb ischemia, Rutherford class from 4 to 6, and with at least 1 tibial artery stenosis occlusion of at least 4 centimeters. And after an optimal balloon angioplasty checked by angio and by duplex without flow-limiting dissection, will exclude patients that need below the ankle angioplasty. The primary endpoint is 6 months by angiography delayed luminal loss, and the secondary endpoint is 12 months target lesion revascularization, target lesion occlusion by duplex, and major amputation. Thank you. Okay, so we had a beautiful overview of what is the future for Sirolimus and Paclitaxel. And we have a couple of interesting questions. One is for Dr. Finn. And there is a Dr. Dangas from New York, United States, that is, are there any data in relation to late events after Sirolimus peripheral balloon angioplasty or stent? And is there a Sirolimus stent with the same elution nanotechnology?
I would say that there are no, the first question I understand, Francesco, was about late events. I think you're going to have much less device-related late events with Sirolimus coated balloons, simply because Sirolimus is much less harsh, and the elution kinetics of most balloons are shorter than for stents. So I would suspect that if you could have more restenosis because the elution the drug levels are not quite as good as what can be achieved with stents. But I think overall the results could be even better because the artery wall will be able to grow over time in response to intimal formation, which is a disadvantage of current stents.
Okay, thanks. And also another interesting question from Sarah from Gloucester, United Kingdom. With all controversy surrounding Paclitaxel, how do we trust this as the follow-up data is not long? So they are asking for long follow-up. What do you think?
Is that to me or to the other ones?
Oh, to all three.
I'll let these guys chime in. I've already spoken.
Yeah, I would completely agree with that. And so we do need long-term data, and we do need to follow up on this patients who have had sirolimus coated balloons for, I think, a minimum of 2 years, and if possible, carry on up to 5 years.
Okay, and yes.
I'm a nephrologist by training, and we do manage patients post-renal transplant where sirolimus is used as an anti-rejection medication. And so far we have, I mean, it's a drug that we are very comfortable with if you keep it within the therapeutic range. So in terms of comparison with Paclitaxel, I would not expect the same kind of outcome because we've been using sirolimus as an anti-rejection medication even in our current clinical practice.
Okay, and the last question from Dr. Sikar Natarajan from Chennai, India. Use of multiple drug-coated balloon in this patient. Is there a risk of toxicity? Dr. Chok, what do you think?
So far, I have not encountered any. The mortality at 6 months so far has been completely in line with typical mortality you see with a cohort of critical limb ischemia patients. These are quite high-risk patients, as you can see. They've got a lot of cardiac comorbidities. So the answer to that is no, but obviously we do need to keep in mind the fact is that these are quite low dose and they've got a safer therapeutic window. The normal Paclitaxel coated balloons are in the range of about 2 micrograms per millimeter square. For sirolimus coated balloon, for the Magic Touch, it is 1.27 micrograms per millimeter square. So it's a much lower dose.
Oh, and I have an interesting question to the next studies. You reported patients with critical limb ischemia and you had more than 200 millimeter of lesion length, but there was only 30% of occlusion. How do we deal with all these differences in population? Because also the Paclitaxel trial had 50% of patients with end-stage renal disease, but then he had only stenosis, no occlusion. I mean, patients with end-stage renal disease, they got occlusions. And maybe if you report stenosis, that means that you don't treat the occlusion. We should agree to find a similar population to compare the study results.
Yes, there is, I would completely agree with that. In some patients, anecdotally, when I reviewed the results of the XTOSI study, for patients with long CTOs, especially for tibial arteries, particularly the ones that needed retrograde access, and if you are not in the intraluminal and you are in the subintimal space, the results for those are not as good as compared to stenosis or occlusions which are treated successfully by true intraluminal crossing. However, for practical purposes, you know, our patients are a combination of occlusions and stenosis. So for the purposes of the future BTK trials, we will be including both stenosis and occlusions. However, we will be excluding patients who need retrograde access.
Okay, so I think that there is another question from Dr. Human from the United States. What is the amount of sirolimus for therapeutic level, and for how long should therapeutic level be maintained? This is an interesting question for Dr. Finn, and I think that the longer it stays in the vessel, the better the outcome.
I would agree with you. I think the minimum amount we need in terms of biologic levels is 30 days. If we can go for 30 to 60 days therapeutic levels, we'll have good results in terms of preventing intimal formation. So I would tell you that, and I agree with you, Francesco, the longer you can go, the better. The only issue is the longer you go, the more additives you have to add to make the sirolimus stay there. So there's got to be some equilibrium in terms of these first generation DCBs, how long we can make the sirolimus stay, but they must stay for at least 30 days.
We have always seen studies with Paclitaxel, like the ACOART, is that we delay the restenosis, but it comes 1.5 years, 2 years, then it comes back. In my opinion, if we can keep some drug elution technology for longer time, maybe we overcome this problem.
And you may have an effect of paclitaxel only in terms of constrictive remodeling at late time points. Because it generates a lot of fibrin and cell death, it may cause worse remodeling in the long run than sirolimus.
So I think we can conclude the session. Professor Greenfield.
Yeah, thank you very much. Very enjoyable. If you put together the paclitaxel session we had almost 2 weeks ago, and this with the Liistro drugs, it makes very good viewing, and we will have learned an awful lot. I'd like to thank you, Francesco, very much for the way you've chaired this, and the speakers, Dr. Choke and Aloke Finn, and Dr. Suai, thank you very much, and to Concept Medical for sponsoring this excellent addition to the day.